dear audience, let me present my PhD topic on hormonal and non-hormonal treatments for oncological and emergency contraception cases. My name is Lotti. I am an MD PhD student and graduate medical student, and I came from the Department of Obstetrics and Gynecology clinic. And I consider it very important to help women in various gynecological problems with the best possible solution, and to achieve this I would like to deliver to these patients the best therapeutic options and scientific knowledge too. One of my research goals is investigating the effectiveness and the safety of the treatment of vaginal atrophy in women with breast cancer treatments. And the other topic, but equally important, is the investigating the effectiveness and safety of IUDs in emergency contraception. Let me talk a few sentences about the vulvovaginal atrophy in women with breast cancer treatment. We know that breast cancer is one of the most common cancers globally, with 2.3 million new cases registered annually. And there are many treatments, but some treatments can cause a really serious side effect, vulvovaginal atrophy, which affects, we can see, more than half of these patients. This side effect can cause really bad symptoms such as dryness, burning, and dyspareunia, and which all can reduce the quality of life of these patients. There is a lack of the adequate treatment and the patient management. That is why we would like to investigate the use of the hormonal and non-hormonal treatments of vulvovaginal atrophy in women with breast cancer treatment. Our clinical question is that what is the most effective and safest treatment for atrophy in breast cancer treatment? And the most important thing, our clinical implication, that we can provide better quality of life for breast cancer patients. We did the systematic search, and after the selection, we got 19 articles, and we collected the data. We finished the analysis with these outcomes, and I would like to show our results. First, we can see the vaginal health index change in laser-treated vulvovaginal atrophy before and after. And vaginal health index is a score system, and in this score system we can talk about the presence of atrophy under 15. And we can see that after the treatment these values were higher, and they already exceeded the threshold of the atrophy. So we can see that after the treatment the patients felt better. The other result is the FSFE, which means female sexual function index. And with that score, we can assess the patient's satisfaction in sexual functions. And we can see that after the treatment, they were more satisfied, and we know that happy wife, happy life. So the other result is the vaginal pH. And we can see that after the treatment, the values approach to physiological value. And we measured the changes in dyspareunia with visual analog score, where we know that 0 is no pain, and 10 is the pain of childbirth or the male flu. And we can see that after the treatment, these values decreased, and which means that the patient felt better. The same can we see in the changes in dryness. So here we can see also the values decreased. We conducted an overall analysis that gives a comprehensive picture of possible treatments. And in previous year, there was no such comprehensive meta-analysis, but we have some limitation. For example, there is little available data, and the high heterogeneity of the included studies. Most of them are single-center and non-randomized, and there is no sufficient data on the long-term treatment. In conclusion, we can say that we see significant reduction of clinical symptoms after the laser treatment, and topical, hormonal, and non-hormonal treatments show less progress, and we can see an improvement in vaginal health among breast cancer survivors. The implication for practice is that the early intervention is really, really important because it can decrease the decline in sexual function, and the unquestionable importance of the applying research findings in clinical practice is widely acknowledged. The implication for research is that the future studies adopt a uniform reporting format for their outcomes to facilitate comprehensive analysis. More RCTs are needed on this field for higher level of evidence, and the long-term effects of the use of these different technology on vaginal tissue should be investigated. We would like to complete our manuscript in a week, and after that we will send for an internal review. And let me talk some sentences about the investigating the effectiveness and safety of IUDs in emergency contraception. We know that unintended pregnancy is a really big problem in the world. Almost half of all pregnancies are unintended, and we can see that almost half ended in abortion. In Hungary, it means a problem too. We can see this Hungarian data. And we know that there are some solutions for the unintended pregnancy. The most common practice is the progestin-only pill, but we know that the most effective solution is the copper intrauterine device, but there is a lack of the evidence of safety and efficacy of IUDs. That is why we would like to investigating this method in emergency contraception. Our clinical question is that what is the difference in effectiveness and safety between IUD and oral contraceptive pills in emergency contraception, and we would like to give a more personalized emergency contraception. We did the systematic search, and after the selection we got 33 articles, and now we are currently working the figure and tables and the grading, and after that we would like to start to write the manuscript. These are my two ongoing projects, and I would like to complete one of them in July and the other in September. As closing my presentation, I would like to say one sentence that I think we hear often these days, or I get it at the end of every day, that how far did you go with the writing article today? So thank you for your attention.
Thank you for your presentation. I'm asking about your first project. What was the average follow-up time? Because you said that longer follow-up is needed.
Unfortunately, the follow-up time was 3 months, or there was some articles with 6 months, but we need more time. I think they would like to investigate it in 1 year and after that too. So yes, 3 or 6 months was the follow-up time.
For the great work. I maybe lost something from the second project. You're comparing the estrogen pill or the combined pill, which is taken usually 1 or 2 or 3 days after the intercourse, to an intrauterine device, acutely inserted into the uterus of the woman just having the intercourse?
Yes.
And is it viable? I mean,
yes, in the USA they use it. In Hungary we give the progestin-only pill for these cases, but in the USA they use it more commonly, and they can give the intrauterine device more than 3 days, so in 5 days, but they are investigating that maybe in 10 days they can give the intrauterine device too. And for example, some patients, like obese patients, in that case, the progestin-only pill is not so effective, maybe, and in that case, they can get intrauterine device too because it is effective. So
okay, so for a longer period, and for some populations.
Yes, and for the childbirth too, because progestin-only pill is 1 pill, and after that they can cause again the unintended pregnancy, but for an intrauterine device they will be safe for 5 years. And for the unintended pregnancy, the intrauterine device is much more better solution. But yes, we investigate that it is effective or safe.
Thank you very much.
But this method is used all over the world. I mean, the acute insertion of the intrauterine device after the unprotected intercourse. And especially in the US, it's just a remark, they had some issues in the last decade on the effectivity of these progestin-only pills as an emergency contraception because of the very high frequency of severe obesity in the US. And in these severe obese the normal dosage, the normal dose of progestin-only pills is frequently not enough. Thank you. But we have one more question here.
One theoretical question. Okay, there's an obese patient. We insert this IUD, and maybe after the next month we take it off. For example, in an obese patient, so can we use it like just for a month, or what's the shortest? It's just a theoretical question because in the practice, these patients would like to use it for 3 or 5 years. But any information about which is the shortest time interval what we should use it?
Yeah, in these articles, there were some patients who give up these IUDs in a month because of the side effects. So yes, it can cause pain and bleeding, but I think it has more economically effect, like it costs more than a pill. So if we put off in a month, then yes, the economy is not so good, but every time we can switch for the other contraception. So it's not a limit for the shortest time.